seen me around, and I work with the sarcoma team, and we're having a discussion about compartment syndrome. I think it's a fairly common topic. It's quite important. How long is it supposed to last?
30 minutes.
30?
A little bit longer if you like, it's fine.
I'm known to talk too much, but
No, it's alright.
I'll just try and keep it brief and simple. I feel it's pretty straightforward. It's something we're quite conversant with, and particularly chosen it because orthopedics is basically a chill specialty. We don't wake up at night and run up and down. But there's just very few incidences where you literally have to wake up and run up and down into it. And one of those lists is compartment syndrome. The other issue is when you have, say, a fracture or you have tumor that is associated with vascular bleed. You know, those are very rare instances where you have orthopedic surgeons running up and down. You know, and we've chosen to talk about compartment syndrome today, basically because of its clinical importance. And I just feel like the learning objectives should be simple, should be clear. We just understand what compartment syndrome is, what causes it, how does it present, and what should we do as junior doctors on the ward. Just a quick summary. Basically, a compartment simply contains muscles, bone, neurovascular structures, all wound up in a fascial covering. So basically that's a compartment in a limb. And any increase in this pressure within the compartment would obviously cause a decrease in tissue perfusion, which would obviously lead to ischemia. And like we all know, each of these tissues have different times at which they survive. The muscles, usually anything beyond 6 hours, the muscles would obviously die off. You know, the nerves can stay a bit longer, but not too long. Invariably, once it starts getting to 8-12 hours, most of the tissues would obviously die. You know, so in any case, whatever is causing the increase in pressure within that compartment, you need to resolve it. So basically, compartment syndrome is an acute emergency. It needs to be identified early, and you need to take definitive action to stop it. Otherwise, it has devastating consequences, and top of it is limb loss. And it's quite a debilitating thing if you've seen it happen, you know, especially because it's quite preventable, and most times the patients would usually voice out their complaint at some point. You know, sometimes in life there's some instances where things happen. I mean, you couldn't prevent it; it just happens. But there's some other instances where they're quite preventable, and at some point the patient may have voiced their concerns or complaints, and then it's a bit ignored, and they're not picked up in time, and then you end up with a limb loss. So it's quite debilitating, and no wonder it's also quite litigated for the doctor. Okay. So usually what would commonly cause compartment syndrome would be basic things, and the basic things would be tight cast, which would be one of the most common things we'll encounter on the ward. So post-operatively, or patients who have just had a fracture or a sprain, we've just applied a cast to the limb, upper limb, lower limb, and the screaming of pain. That's the first sign of an increase in compartment pressure. It doesn't mean the compartment syndrome has developed. It just means there's just an additional pressure added to that compartment in the limb, basically. But much more common is a long bone fracture, and there's usually this assumption that open fractures don't cause compartment syndrome. That's not true, okay? Open fractures are known to cause compartment syndrome, and once you have an open fracture, you shouldn't rule out compartment syndrome, okay? Because you still have a lot of pressure within that compartment, either proximally or distally. Sometimes the open wound is just a puncture wound, which is not enough to decompress that compartment. But much more commonly, simple fractures wouldn't give you compartment syndrome. Whenever you look at the x-ray, or before you even get to that, from the mechanism of injury, you can suspect that a patient may develop compartment syndrome. For example, the patient has just been hit by a high-speed vehicle traveling at 120 miles per hour, with multiple broken bones, polytrauma, you should have a suspicion that it's possible that because of the energy transfers to that limb, the pressure within that compartment would be much. So I would anticipate that compartment syndrome may appear here. Or sometimes you look at the x-rays, a comminuted fracture, like a segmental fracture, or the bone broken in multiple bits, that can signify likelihood of developing compartment syndrome. Again, the anatomic sites can also guide you. Okay, the leg is the most common site, followed by the forearm. Okay, then closely followed up by the hands and foot. But of course, it can happen in any compartment. And don't forget the buttock. You can have compartment syndrome in the buttocks. Okay, so anywhere you have tight facial covering, overlying muscles and tissues, you can have compartment syndrome there. It's not so common in the thigh, but it does happen, all right? So always have a high index of suspicion. So if a patient comes with tibial fracture, you have a much higher index of suspicion than a patient coming with, say, an arm fracture, okay? It can still happen in the arm, but there's a little bit more room, for swelling, edema to happen in the arm as compared to the leg. The leg is mostly occupied by the tibia, and the facial coverings there are very tight, and any further increase in any contents in that compartment could increase the pressure. Okay, so you can have it happening in crush injuries. We've talked about high energy transfer, animal bites. Okay, this release toxins which can cause severe edema in tissues, and that can also increase the pressures in the compartment. Of course, other soft tissue injury, frostbite, we've talked about multiple bony fractures, are other causes of it. So basically, if we look at this, this is one of the most common circles you would see in pathophysiology of compartment syndrome. And basically, you see the point where you have the ischemia, which is usually the end product. But before that, you would have an injury, which would either be from a tight compressive dressing, burns, cross injury, crush injury, fracture, whatever the causative mechanism is. This would lead to edema, which would increase, obviously, the pressure within the compartment, all right? And then that would reduce the blood flow to the tissues in that compartment. With reduction of blood flow, if you don't do anything, the tissues would undergo ischemia, and more ischemia will cause what? Edema, and then you have this vicious circle, all right? So it's a condition that basically perpetuates itself, okay? It sets up a chain reaction that just keeps going and getting worse, all right? And the only way to relieve it is to decompress that compartment, right? That's just simply the only thing. There's no other thing. That's the only way to break up that circle, all right? So why is it dangerous? Why are we talking about it? Because if you don't act, the nerves could die, and you could have ischemia, okay, which could lead to cell death, and then you have muscle contractures, okay, in the limbs, and ultimately, if it's not acted upon, you have loss of limbs where you have gangrene. So if you're able to act in time, even if the nerves, undergo some functional changes, they're able to regenerate if you act in time. But if you allow this to perpetuate for too long, usually 6-7 hours after that, it becomes very unlikely to salvage that limb. So how does it present? The most important thing I want you to take away from here is pain. Forget about the other P's. I know you know about the pulselessness, pallor, and all of those. Those are late findings, okay? By the time a patient is developing those symptoms, you've most likely missed it, okay? So usually pain out of proportion to the original injury would be your clincher to compartment syndrome, all right? So they would be screaming of pain, and almost always they would have had, adequate analgesia, okay, if they're developing compartment syndrome. Fractures are painful, okay? So a patient comes with fracture, complaining of pain, you suspect compartment syndrome and has only had just one analgesia. You can't think of compartment syndrome at that point, okay? Because you haven't exhausted the analgesic requirements for that patient, all right? But again, they may have had all of the analgesia, and they have classical symptoms of, pain out of proportion, swollen, shiny limb. Those are classical symptoms. Maybe happening in the legs, okay, or forearm, okay, high severe energy injury. So you start, adding all of those symptoms and signs together. That should raise your index of suspicion. Okay. The other signs would be paresthesia. Again, this is a late sign. Feeling of numbness, discoloration in the limb, pulselessness, and of course paralysis. You already have ischemia when you have paralysis. Okay. So you really don't want to wait for all of those other ones. So just focus on the mechanism of the injury, pain, and how does the limb appear. Okay, I think those three factors will make you pick up almost always compartment syndrome in conscious patients. Okay. So how is it diagnosed? This is a clinical diagnosis over 90% of the time, except in the 10% of cases where you have children because they can't verbalize, right? So you can't trust their judgment. Patients with altered mental status, okay? Patients who are unconscious, you can't tell that they have pain, okay? So you may rely on some other means to diagnose compartment syndrome, but largely this would be the rare instances, okay? Most common instances, your patients will be conscious, they will be awake, they would have an injury that they would respond to, and they would also complain of pain. The different ways of measuring compartment pressure, okay, they are usually a weak handheld device which you can place into the suspected compartment and read off the pressure, okay. There are mercury-driven devices which you can also use, but this is a very common method, and basically you need to insert this device perpendicular to the skin, okay, that's one thing you should note. Two, it's easily available. I think you can have them in the ward if you ask, okay. It should be inserted 5 cm close to the fracture site, okay, to get the right pressure within the compartment, okay. And for the limb, you should insert it where you think the pressure would be the most, okay. So for example, we talk about the leg. You have 4 compartments in the leg, you have the anterior compartment, you have the lateral compartment, you have the superficial posterior and the deep posterior. So not uncommonly, you would have isolated compartment pressure being increased. So you can have an anterior compartment pressure being elevated alone, okay, and the other compartments are not under pressure, okay. Some other times you can have all the compartments under pressure, okay, but most times you would have 1 or 2 of the compartments being elevated in terms of pressure, okay. So if you're really going to measure the compartment pressure with this device, you need to place it into the right compartment, all right. So if you think it's going to be in the anterior compartment, that's where the pressure is most, you need to place it 1 cm lateral to the anterior border of the tibia, 5 cm close to the fracture site. That's where you need to place this device, okay. Again, like I said, this would be in cases where you are not sure, where the clinical symptoms does not tally with the mechanism, or in patients who are unconscious, or maybe in children, or patients with head injury, or in other patients who are confused, who you don't trust their judgment, right? If you think the pressure is elevated in the lateral compartment, then you need to place it in the lateral compartment, just at the junction between the fibula and the anterior edge of the tibia, okay? For the superficial, for the posterior compartment, you need to place it 1 cm behind the medial border of the tibia. That's where you need to place it. Again, remember, place it close to the suspected fracture site. You don't need any investigation to diagnose it. Sometimes, when the findings are equivocal, you may need to do an X-ray to rule out a fracture. All right. But the most important diagnostic study that correlates well with compartment syndrome is to measure the delta pressure, which is the right side pressure. Okay. What you do here is you measure the compartment pressure, right, with that device, right, and then you subtract that value from the patient's diastolic pressure. Once the value you get is less than 30 millimeter mercury, it's almost always compartment syndrome. All right, then you need to act. If the value you measure is greater than 30, then it's not compartment syndrome. All right, but you need to be careful about the diastolic pressure. All right, intraoperative diastolic blood pressures can be low, so it can give you a false value. All right. So what should you do? High index of suspicion. All right, you should always have high index of suspicion. And again, like I said, it should be a combination of the mechanism of the injury, pain out of proportion, and how the limb appears. You know, I think with these three factors, you should be able to make a diagnosis. You should follow the ATLS approach again, because most of these patients would be polytraumatic patients, and you need to identify life-threatening injuries first of all before limb-threatening injuries. All right, don't be distracted by the limb. So you need to be systematic in trying to rule out compartment syndrome. So first of all, is the affected limb swollen? If it's swollen, has it been elevated appropriately? All right. If it's a post-surgical patient, you know, you need to be aware. You need to go through the operative notes to be sure of what they did. You know, to document, to find out if there's any, you know, post-operative incidents that may have predisposed to possibly a reactionary hemorrhage or a hematoma or a collection. All right. So, has the patient received adequate analgesia? So you usually go through the drug chart and make sure the patient has had optimum analgesia. Is there any tight casts within the limb? You know, so if there is, you have to loosen this completely. Okay. And if the patient is still in pain and you've ticked all the prior boxes, then you should consider compartment syndrome. All right, it should be top of your differentials. All right. And again, of course, you should escalate this as to junior doctors, all right? So once you have that suspicion, just inform your senior, basically. Yeah, don't sit on it. Don't wait for an additional 1 hour or 2 hours, okay? It may have been developing before you say. That may be the 6th hour, okay? So always escalate it if you've ruled out those prior incidents. So the definitive management is basically fasciotomy, okay? And once you've made the diagnosis, you should be in theater within 30 minutes, okay? And within 45 minutes of making that decision, I mean, the fascia should be released, okay? It's not a complex procedure. Basically, all you're doing is you're making a skin incision, you're going through the subcute, and you're releasing the fascia, okay? All limbs go through this anatomic pathway, okay? You have the skin, you have the subcutaneous tissue, and then you have the fascia. Once you release the fascia, you release the compartment, okay? And then that decreases the pressure. You need to get the plastics involved because, of course, you need to deal with the wound you have created, okay? We'll talk about closure subsequently. So most times, this would usually be associated with fracture, right? So you need to stabilize the bone, because if you don't stabilize the bone, that would further cause more tissue edema, which would worsen the pressure, all right? So most times, the patients would be on an X-fix, okay, post-fasciotomy, right? The wounds are not closed immediately, because of course, if you close it, you're going to increase the pressure, all right? So you want to leave the wounds open, you want to elevate the limb at heart level, okay, not more than that, not below that, all right? You just want to keep the leg at the heart level. And then, of course, you want to re-inspect the wound, usually within 24 to 48 hours. If you've done a thorough release, okay, and debridement, yeah, you may delay further review to 72 hours. But usually in the setting of open fractures, you know, suspected compartment syndrome, you're expected to go back to theater, you know, after 24 to 48 hours to have a second look, you know, to take out dead tissues and, you know, release further compartments. So the general principles, it doesn't matter where the compartment pressure is happening or is increasing, whether in the upper limb or in the lower limb or in the hands or in the feet. You need to make early diagnosis, okay, which is what we've been hammering on. And you need to make long extensile incisions, okay? You shouldn't be shy of incisions. Usually, as one progresses through their surgical career, your incision, you know, size reduces as you gain more experience. But this is one instance where you have to maintain long incisions, because if you don't make a sterile incisions, you don't decompress the compartments, completely. So if you're making it in the leg, you need to make incisions right from the head of the fibula down to the lateral malleolus. Okay, if it's in the thigh, you make it right from the greater trochanter down all the way to the lateral cord down of the femur. Same thing with the upper limb, same thing with the lower limb. I'll show you pictures of how you should do this. And once you've made your skin incision, you should release all the facial compartments. Okay? Alright, it doesn't matter if you suspect one compartment is involved or not, just release all of the facial compartments. Okay? You preserve the neurovascular structures. You should be aware that you have important nerves in these limbs, especially cutaneous nerves, and also important neurovascular structures. For example, in the leg or the lateral aspect, you should be aware of the superficial peroneal nerve running on the lateral compartment, right? And then on the medial side, you should be aware that you have the, of course, a great saphenous vein, which is important. You can't save, you can't ligate. But again, you also have the saphenous nerve, which is an important, sensory nerve. Okay. You should debride all necrotic tissues. This would be in the setting of, say, open fractures or grossly contaminated wounds, or in the case of the delayed compartment syndrome, which we'll talk about shortly. And then you should aim to cover the wounds within 7 to 10 days. Sometimes you can aim earlier if the swelling has really subsided, but usually within 7 days. So we'll look at the leg, which is the most common site. Okay, there are two ways to decompress the compartment. You can use a single incision, or you use a double incision. So the double incision is most common. Okay, it's what you would see most frequently, and the reason for that is it gives you a much better exposure. I mean, they give comparative exposures, both the single incision and the double incision, but the difference is that this is less technically demanding, right? Okay, the double incision is less technically demanding and is what most people would advocate for. All right, there's nothing wrong with the single incision, but then you have to be really experienced, okay, to do it. So I would say, if you have to do any, please do the double incision. All right, and what you're basically doing is you're decompressing the 4 compartments of the leg through 2 incisions, one lateral and one medial. Okay, so the lateral incision decompresses 2 compartments, the anterior and the lateral compartment, while the medial incision decompresses the posterior compartment. The posterior compartment is divided into superficial posterior and deep posterior. So if you look at that diagram, the one on your right hand side is coming from the lateral side. Okay, so you make the incision from the top of the fibular head down to the lateral malleolus. Okay, I would suggest you make this incision longer than it appears on the screen. Okay, so go a little bit up and also a little bit down. Go through the skin, subcute. Of course, be mindful of the superficial peroneal nerve running on the lateral side. Then you make an incision, okay, 1 cm anterior to the lateral intermuscular septum. That decompresses the anterior compartments. And then 1 cm posterior to that septum, you decompress the lateral compartment. So the lateral incision decompresses the anterior leg compartment and the lateral compartment. The medial incision is usually made 1 finger breadth or 2 cm behind the palpable medial border, posterior medial border of the tibia on the medial side. Make the incision. You incise the fascia over the superficial posterior compartment, all right? And then there's a deep posterior compartment which you need to decompress, all right? An important landmark is the soleus, okay? So if you're able to detach, you have to detach the soleus from its proximal attachment to the tibia. That's the only way you're sure you've decompressed the deep posterior. So in the leg, the most frequently ignored compartments to be decompressed is the deep posterior. All right. Most people will decompress the anterior, lateral, superficial posterior, but the deep posterior is something you may not decompress adequately. Okay. So we usually take out the soleus bridge, which is the attachment of the soleus to the proximal tibia. So until you've taken that muscle down, you haven't fully decompressed the posterior compartment. Because remember, the neurovascular structures are what is going to be compromised in terms of the pressure. And in the anatomy of the leg, the vessels run in close proximity to the posterior border of the tibia. So until you've taken that deep posterior muscle down, you haven't fully decompressed that compartment. Okay, so this is the image of the tibia on the medial side. Like I told you, on the medial side, again, go a bit proximal, go a bit distal. All right. Now this is a single incision, which again is directed towards the fibula. All right. Again, from the fibular head down to the lateral malleolus. All right, and then you walk your way around the fibula to decompress all of the compartments. Like I said, it requires a lot of experience to do this, and the exposure is a bit difficult, all right? So you can read about it. The advantage is it avoids 2 incisions. You just have 1 single incision, all right? That's the advantage of it. If you have isolated compartment pressure increases, you can't use it, all right? But usually, for doctors like us, we would prefer to do, the double incisions. I've put a picture of the forearm because it's the next common site. So you can have different compartments in the forearm. You have the volar compartment, right? You have the dorsal compartment, and then you have the lateral compartment, which is the mobile ward, right? The mobile ward contains the brachioradialis and the extensor carpi radialis muscles. Basically, the incision of the volar compartment follows that curve, all right? And you can see that the incision has extended a bit into the hand. That is to decompress the carpal tunnel. All right? Okay? So it goes all the way, it goes through the ulnar border and curves back to the radial border. All right? So what you need to do here is there are 2 fascias you need to decompress on the volar surface. Okay? There is the superficial muscle and the deep muscles. Remember the flexor digitorum superficialis and flexor digitorum profundus. So if you make your incision and you go through the subcute and you release just 1 fascia in the volar compartment, you have only decompressed the superficial muscles. There is the deep muscles where you have the FDP, the pronator quadratus, and the rest. Okay? So you need to decompress the superficial muscle, slide them away, and then make another facial incision to decompress the deep muscle. Okay, very important in the volar surface of the forearm. In the dorsal compartment is just 1 fascia. Make a single skin incision, subcute, release the fascia, and then you're over dry. Alright? Put image for the foot here. So usually for the hands, you have 10 compartments, both in the dorsal. Alright, in the hand. You usually make 2 incisions on the dorsal aspect of the hand. Alright, so usually between the 2nd and 4th web space to decompress the hand compartment. Also may have to make incisions on the terna and hypoterna eminence also to decompress that. And then also for the foot, you can make those 2 incisions, usually in those web spaces, alright, to decompress the dorsal group of muscles, and then you make 1 on the medial border of the foot, alright? So closure, usually they would require some form of, grafting. Because what happens is, because of the swelling, it may take time to come back, so you may need to put some skin grafting. You can't close them directly, especially if the swelling is not so much. You picked it up early, all right? Usually after 5-7 days when you go back, it's possible to close them primarily. What some people do is release the compartment pressure initially in theater, and then you can put running, running non-absorbable stitch in the skin. You don't close it up, you just leave it loose, all right? Patient goes to the ward, the swelling comes down, and then you find out when you're going back to theater, you can sequentially tighten it, okay? It tends to avoid you doing a skin grafting, all right? That's something you can do, all right? But in other cases, you may have to do a skin graft.
I can ask a question, sorry. So a graft in this case, wouldn't it be directly on the muscles?
Yes. The muscle is a graftable bed.
Yeah, but so we've removed the fascia, any covering of the muscle.
Yeah. So what you've basically done is, you've identified it before any ischemia, so your muscle is healthy, right? You've only just released the fascia, right? So what you have is the mycium, and then you have the muscle underneath, right? So all you just need to do is just place a skin graft on it. The healthy muscle is a good granulation bed, right?
So as long as you know that it's healthy.
Yeah. Yeah. Of course, it's going to be healthy because you've released the compartment pressure. It's not ischemic. And usually when you come back in a couple of days, the swelling has reduced. You may be able to close the distal aspect, but the central aspect will be difficult. So you just, you don't have to graft from top to bottom. Sometimes it's a bit difficult to graft from top to bottom, but most times you will be able to close a portion of the wound you've created. But usually the central bits will be difficult to close, okay? And then you just graft that part, correct? Again, with open fractures, grossly contaminated tissues, necrosed tissues, at the time of your initial fasciotomy, you may have done some extensive debridement, or you may have gone back to theater to debride more muscle. At the end of the day, when you're coming to close it, you may not have healthy beds, okay? In that instance, you wouldn't be able to graft, then you have to escalate it. You go through your reconstructive ladder, right? You have primary closure, you have skin graft, you have local flap, you have regional flap, distant flap, and free flap. Okay? So we just go through that reconstructive ladder. So you may need a flap, okay? And to get definitive closure. But most cases that we would experience should be closed by a combination of primary closure and skin graft. Very rarely would you need a flap to close fasciotomy wounds, okay? So what happens if you miss the compartment syndrome? So usually maybe after 6 hours or 8 hours you've missed it. There's usually a debate, would you still go ahead to release it or not? Again, a bit controversial, but usually everyone agrees if it's more than 12 hours, and there's inevitable tissue damage, there's no point in releasing that compartment, because what happens is you're just going to release toxins, you're going to release, muscle tissues, which would go block your renal tubes and cause more problems. So what you have to do there is an amputation. Okay. Borderline cases where you're not quite sure, you've missed it, but you're not sure, then you have to be very physiological in your management. Okay. This patient would need adequate fluid resuscitation, right? You may need to take this patient to a high dependency unit. Okay, you may still perform your fasciotomy, okay, maybe between 6 to 8 hours. You can still perform it, but then you have to make sure that the acid-base balance of the patient is corrected, you have adequate fluids, you have provision for organ support, okay, in case they run into trouble after your release, all right? But if you've gone past 12 hours, most people would agree you just amputate, all right? That's safer for the patient. So in general, in conclusion, this is an orthopedic emergency that requires a high index of suspicion, right? And immediate fasciotomy is needed to prevent limb loss. So we've just basically gone round compartment syndrome. I hope I haven't gone too technical.
Okay, that's great.
Do you have any questions? Any clarifications? Any clinical experience?
I have a quick question.
Yeah.
Just about, obviously the sort of first steps of investigating if you're suspicious of compartment syndrome, you take the card, stop it, things a bit tight.
Yes.
Would you suggest having a chat with the senior before you do that in here? Some people get
No, I wouldn't.
Yeah.
I wouldn't, as far as the doctor coming to see the patient, and I think, I think there's it depends on what has been done, basically. Okay, depends on what has been done. So basically, you've done through your own steps. You've made sure they've elevated the limb, right? The limb is appropriately elevated. They've had adequate analgesia, right? Sometimes we put casts usually to reinforce what we've done surgically. Okay, so and in other times the cast is just supportive. So it depends on what that cast has been applied for. Sometimes the cast is part of the treatment, the operative treatment. So in that case, you wouldn't just want to take it down, all right? You want to get a senior opinion in that instance, all right? And that's if, I'm assuming you're making the right call. You've gone through the notes, all right? You've gone through the surgical notes, the operative notes. You're part of the team. You understand that, okay, this is quite an unstable fracture. Even though they have put a plate or a nail, they have also put a cast, to support the fracture, all right? In any case, you want to get a senior opinion at that point. Okay? But if it's just a patient who has been on the ward, it's just a cast applied just for provisional comfort or something like that, yeah, you can't take it off before informing your senior. I don't think there's anything wrong. Nobody would say you've done the wrong thing for taking off a cast where you suspect an increased pressure. I mean, generally, sometimes we take off cast not because of compartment pressure. Sometimes the cast is just too tight, causing pain, right? You have to just let it loose, you know. You don't have to take it completely. You may just have to expand it to release the pressure, all right? And if it's a full cast, you may have to split it or bivalve it, all right? Yeah. So I think it's a good call. If you think the patient has elevated appropriately, there's been good analgesia, I think the next line would be to just release the cast. Yeah. It doesn't change anything. The cast can always be reapplied, right? A limb, even if you lose a reduction, it can always be reapplied. But then if you haven't done that and you have a limb loss, then everybody will be like, but you saw, why didn't you choose that? You get it? So it's one of those instances where even if you take the patient to theater to do a fasciotomy and it is negative, and in some series it's about 20% negative fasciotomy rate, you're still not wrong.
Yeah.
Yeah. You're going to be wrong if you don't do anything.
And it can be closed primarily more easily.
Yeah, and you can always close primarily, right? Yeah. So it's one of those, yeah. Always get a senior to review, all right? Yeah. So, Sakai, no questions? Oh, really? Okay, I guess we'll choose, much more tougher topic next.
No, that's a great topic actually. We didn't get it before, and it's something that we can deal with. I did look with only 2 or 3 cases back home, and one of them was a burn victim. I was actually astonished by how well, so it was in the hand basically, and we also did these, second and fourth in the spaces. It was quite a young boy who had 3rd-degree burns, and I was astonished that the moment we touched the fascia compartment, there was no bleeding actually, not that much bleeding,
and
just very minimal.
You just literally saved that hand, I mean, if you had left that for a couple of hours, what you have is it's just going to have the ischemic contracture, and that's just going to be a useless hand.
Yeah.
It may still look pink because you may have collaterals, but the muscles are just going to be contracted. You may not have the classical gangrene dark, and that's the thing, about the Volkmann ischemic contracture, because the muscles are just going to die underneath, and then the superficial tiny vessels are just going to keep the skin alive, but then you can't use it. You can't use the hand. It's going to be a useless hand. And then you have to do muscle transfers and things like that, which can be totally preventable by just 2 or 3 incisions in the hand. So again, hand, foot, usually sites that are neglected. Buttocks again. Okay. Yeah. All right. Okay.